May I call to the podium Dr. Ahmed Sameh from Vascular University. He will speak about the aortic dissection growing experience at Korean school a single hybrid aortic center.
Thank you, Chairperson. I am Ahmed Sameh from Vascular University. I will talk about practice for aortic dissection, how it's changed from just simple TVAR to stentless TVAR over a period of years in one single hybrid aortic center, Gangnam Severance Hospital. This is my introduction, just in brief. Acute aortic syndrome include aortic dissection, intramural hematoma, penetrating aortic ulcer, and two major classifications, the Beakey and Stanford. And the clinical presentation include.
It's only in the best few seconds. Can you, Ahmed, use your voice, please? It's not heard in the room.
The clinical presentation include sudden severe pain, hypertension, diastolic murmur, pulse deficit, focal neurological deficit, syncope, and in case of ascending aorta, it include acute aortic insufficiency, acute myocardial infarction, tamponade, hemothorax, stroke. And diagnostic modalities include contrast-enhanced CT, MRI, transthoracic echo, and transesophageal echo, and aortography. This is open Google access for different modalities. You can see the difference between true lumen and false lumen in different modalities. The IRAD recommend after follow-up of mortality for type A dissection and type B that first option for type A is surgery and first option for B is medical treatment. Our hybrid aortic center protocol, when we suspect acute aortic dissection, if patient unstable, we recommend blood pressure monitoring, ventilation, resuscitation, echo, and if the aortic dissection confirmed, immediate surgery, and if other diagnosis match according to the diagnosis. In stable patient, we did initial investigation. If aortic dissection confirmed according to the type, in type A we did surgery, in type B we continue medical treatment, and we interfere in chronic type 3B in case of aneurysmal changes, malperfusion to visceral or major branches, and intractable chest pain. And our surveillance protocol is initial CT-A before at admission, and at 1 month, at 6 months, and at 1 year. I will show one case for 5 years of intervention and follow-up that represent our policy for acute aortic dissection. This patient presented with chest pain. As you see in CTA, diagnosed as type B dissection and retrograde type A intramural hematoma. Our planned operation is stereoriented surgery and ascending aorta replacement, partial arch replacement. On follow-up, on 10 days, the aortic diameter is okay, below the cut edge for intervention, and on 41 day, it's below the cut edge for intervention. But you can see for the magnified picture here, there is penetrating aortic ulcer and high degeneration. So we recommend in this patient frequent follow-up. You can see the CTA at 46th day and 76th day. There is degeneration, but the maximum aortic diameter below the cut edge for intervention. But we reach the cut edge for intervention 5 centimeter, 0.6 at 130 day post-operative. And during the last 3 months, we had the growth rate 11.6 millimeter. So we did the hybrid debranching, zone 1 TVAR. We taken flow from right common carotid to left common carotid and left subclavian, plugging off orifice of left subclavian and excludes the aneurysm through TVAR. You can see initial angiogram and the final angiogram. We used the TX2 Proform device. At 1 month of follow-up and 2 months, everything is okay and the complete thrombosis up to the T7 level. But after 1 year, you can see here retrograde flow around the entire descending thoracic aorta outside the stent graft. By studying this segment, the maximal diameter is 6.4 millimeter. And at initial angiogram, there is retrograde flow that pressurizes the false lumen. So we did our first false lumen procedure by plugging this tear using a vascular plug. At 6 and 12 months of follow-up, there is entire false lumen around the abdominal aorta. So we did angiogram. We found there is a communicating channel here. So we exclude this channel through plug and coil. And after 5 years from the first operation and about 2 years from serial false lumen procedure, we can achieve complete thrombosis of false lumen and favorable aortic remodeling. By revising the literature, we found that TVAR only is controversial. In this study, only 16% of aortic remodeling occur, and this is our own study about the prognostic factor for aortic remodeling. We have, with aggressive TVAR up to the celiac trunk, only remodeling in 65%. The pitfall for TVAR is visceral vessel and intercostal arteries from the false lumen communicating in channel below the endograft that pressurize the false lumen and causing unfavorable aortic remodeling. So to favor aortic remodeling, we have many options: extension of aortic coverage, visceral debranching by hybrid repair or fenestrated device, fenestration technique, and direct occlusion through false lumen procedure. In our institution, we depend on false lumen procedures. We not the beginner, but we follow teleclopel that used the candy block technique and Knickerbocker technique. Also, this is another study support false lumen procedure talking about embolotherapy, and this is a nice study from Journal of Vascular Surgery. Complete thrombosis occur when use adjunctive false lumen procedure beside TVAR. This is our own study. We achieved the complete thrombosis of false lumen when combine TVAR and false lumen procedure in all cases, except for 20% in venous phase image. So our first image from our growing knowledge is that adjunctive false lumen procedure after hybrid TVAR can contribute to successful false lumen thrombosis and favorable aortic remodeling, but the key is closed aortic surveillance protocol. After that, lastly, in the last year, we think about closing the primary tear in the same manner like re-entry tear and visceral vessel tears by using this material, what's named stentless TVAR. This is one case report about it. You can see in preoperative CTA aneurysmal change of descending thoracic aorta. At first, we close the primary tear by plug. There is minimal endoleak that will fade at the end of the procedure. I will show video for this image soon. Then the first communicating channels, intercostal artery, we coiled it. And lumbar 2 artery, we coiled it. And the last communicating channels, lumbar 4, we at first coiled it, but coil migrates, so we plug it. Then celiac artery tear, we seal it through via band. And left renal artery tear, we seal it also through via band. The last tear is a large retrograde tear at left external iliac. We sealed it through via band stent, two overlapping stent. So through this isolated false lumen procedure, without use the stent, we completely exclude the false lumen from the true lumen. And this is the final angiogram at different levels. You can see here no endoleak. What about the true lumen? It will dilate without stent. Yes, it's dilated. You can see the difference in diameter at 3 levels: left subclavian, pulmonary artery bifurcation, celiac axis. The true lumen will dilate and the false lumen will decrease. Also, the pressure change between true lumen and false lumen not high, so the plug will be stabilized, and we can also support the plug with coils from the false lumen. And we are thankful to this silicon model that give us this idea. When you include all communicating channels, primary tear, inter-tear, visceral tear, the true lumen will dilate over months. So my second message of growing knowledge is that stental stivar is a safe, promising procedure that result in favorable aortic remodeling, especially in patients with many inter-tear and communicating channels. And our selection criteria for this procedure, we started with small primary tear, and now we are doing it as standard for all tears. Thank you.
Thank you very much, Ahmed. Very interesting cases.